And this question, sorry, this topic is dengue fever, also repeated in July and June. And dengue is caused by dengue virus or flavivirus. And there is four serotype of dengue, which is from the DNV 1 to 4, and infection with one serotype gives lifelong immunity to that serotype, but only short-term cross immunity to others. Definition: causative organism is dengue virus, and immunity, lifelong immunity to the infecting serotypes, and short-term cross immunity to the others. Risk of the severe dengue is increased with reinfection by a different serotype. Once you're immunized by one serotype, so you will get infected again by another. So the risk factor for dengue travel to endemic area is very important, like the Southeast Asia, like Thailand, Bali, Philippines. You can see a lot of recall travel to Bali, Pacific South America as well. Previous infection, history of the dengue, the patient, and also significantly increased risk of severe dengue. And the patient will have shock syndromes or THF on reinfection with different serotypes. Vulnerable population, infants, older patients, pregnant ladies, comorbidities, pre-existing diabetic or renal failure. Now, clinical presentation, the classic dengue presentation is there is a sudden onset of high-grade fever. Suddenly, the patient will have a high-grade fever, severe frontal or retro-orbital headaches. Okay, so the headaches type is frontal or retro-orbital, and the breakbone pain, the patient will have an intense, very bad muscle pain like myalgia and arthralgia, and the rash there will be diffuse maculopapular rash, often appearing as the fever begins to settle. The warning sign of the dengue is day 3 to 7, the critical phase, which the patient will have abdominal pain, persistent vomiting, mucosal bleeding like epistaxis gingival, or lethargy or hepatosplenomegaly. And also in severe dengue, the plasma leakage would be there, which is the case of shock. The patient will have a dengue shock syndrome, and also severe hemorrhages and multi-organ impairment would be in this step. Investigation for dengue, the first foremost is FPC to see there is a leukopenia in the FPC findings, which is a strongly early indicator for the dengue with thrombocytopenia, which follows the WBC drops. LFT checking, mild to moderate elevation of the ALT, AST would be there, and from the starting date to day 5 of the illness, we will do the PCR or NS1 antigen detection. And from over day 5, sign and symptoms, they will do dengue immunoglobulin M immunoglobulin G serology. Okay, so this means less than day 5, we do PCR. More than day 5, we do serology. Management of dengue, not a specific antiviral, and it's almost supportive care, fluid management, adequate hydration, oral or IV, critical during the plasma leakage phase. Analgesic paracetamol only, NSAID is strictly contraindicated. Public health, dengue is a notifiable disease. We have to notify public health unit immediately. Hospitalization requires a warning sign. If there is severe dengue syndrome or high risk comorbidities, we will admit the patient. Differential diagnosis is with Zika virus, malaria, chikungunya, and also with measles. With Zika virus, the patient will have a bilateral conjunctivitis, red and watery eyes. It's very hallmark for Zika virus. And investigation for Zika, we do Zika PCR through the urine or serum, and the management is supportive. Strict advice to avoid pregnancy for 2 to 3 months post-exposure. The common AMC trap is choosing dengue when they mention red eyes. This is your mistake. So once there is a red eye, so think about Zika virus as well. Malaria is there is a cyclical fever again, and also the patient will be anemic. Rash is very rare. Investigation, we do thick and thin blast films is mandatory. And for travelers, management of malaria is giving anti-malarial like artesunate. And the AMC trap is taking malaria if symptoms start less than 7 days after arrival. Falciparum need minimum 7 days. And also in chikungunya, chikungunya differentiation is immobilizing polyarthralgia, which is particularly affecting the small joint. And also, the investigation for chikungunya is we do serology or PCR. And also management is supportive care. The AMC trap is confusing breakbone back pain with the severe joint stiffness of chikungunya. And for measles, complicated spot is very prominent, and also coryza calf with conjunctivitis. Investigation is measles PCR, management is supportive, excluding from school. Differentiation is differentiating by platelet thrombocytopenia is not typical in measles. Conjunctivitis is in dengue fever. Conjunctivitis can be there, but it is not very common. Very rarely you can see, and it's not a specific sign or symptom. Important points, doctors, the bay biter, day biter PL, which is unlike malaria, mosquitoes, night biters. Dengue vectors, the name is Aedes aegypti, can bite during the day. The malaria is biting during night, but this is biting during the day. Normal platelet trap. The normal platelet trap, remember, in early or mild dengue, platelet would be normal. And leukopenia, lower WBC is often the first lab clue. Thailand or Bali clue is any returning traveler from this region with fever and rash and severe headache, body ache. Think about the dengue until proven otherwise. The critical window risk of shock is the highest of fever supplies in day 3 to 7. This is when the fluid monitoring is most vital. And this table, must do and do not do table, advise paracetamol only for pain and fever, notify public health, advice by prevention using date, picaridin, repellents, and long sleeves. These are the prevention factors, and do not give NSAID, which is increased the risk of hemorrhage, and do not assume as a negative initial malaria test to rule out the repeat of symptoms of persist. Delayed treatment. Do not delay the treatment for serious causes. Important numbers, 3 to 14 days is standard incubation, and day 3 to 7 critical phase, and WBC will show less than 4, 10 power 9, indicating leukopenia, less than 100,000 millimeter threshold for thrombocytopenia, which often is 75,000 in exam records. 7 days minimum incubation for falciparum symptoms before the point away from the malaria. Before I start the recalls, I'm showing you some other information, the last minute review. This is also very important. Think dengue when a return traveler from Southeast Asia or Pacific, other endemic area like abrupt high fever, if the patient has abrupt high fever, severe frontal or retro-orbital headaches, marked myalgia, arthralgia, micropapular or petechial rash, nausea, vomiting, diarrhea, leukopenia, thrombocytopenia, mild to moderate AST, ALT elevation. This is very important for diagnosing a patient with dengue. Okay. And the disease path, there is the disease phase, the patient will be febrile. They will have a very high fever, headaches, myalgia, and gastrointestinal problems. And the critical phase often begins around defervescence, commonly in day 3 to 7, and the patient temperature will be improved while the plasma leakage and shock will be increased. Recovery phase is the leaked fluid is reabsorbed, and excessive IV fluid can now be caused pulmonary edema. The three phases will be under dengue. The best investigation for the initial investigation and confirmatory investigation. Initial is FBC with the serial platelet count, hematocrit, and urinalysis, culture creatinine, LFT, coagulation study of bleeding or severe illness, they contain malaria from whenever epidemiological appropriate. These are all investigation of the initial test. Confirmatory dengue test is early illness, approximately from day 1 to 5, we do PCR or NS1 antigen. After approximately day 5, we do IgM serology. Interpret IgG carefully because it may reflect previous infection or secondary thing. So now in management, if the patient is stable and complicated, we start with oral rehydration, paracetamol, clear return precaution, clinical and laboratory follow-up where appropriate, with warning sign of shock or inability to maintain hydration. If these are in the stem, then we will admit the patient in hospital, carefully titrate isotonic crystalloid, frequent assessment of blood pressure, capillary urine output, and also checking respiratory status. Escalate the patient if there's a severe dengue to experience emergency infectious disease to ICU team. So this is the first line of management. So easy. And now these are contraindications. Don't give aspirin, don't give ibuprofen, don't give naproxen, or don't give IM injection where avoidable, unnecessary invasive procedures. Warning signs are severe or persistent abdominal pain, persistent vomiting, accusal bleeding, lethargy, restless, hepatomegaly, then reduced urine output. These are all warning signs. Severe dengue, how we diagnose it. So that there would be all of the severe plasma leakage causing shock or respiratory compromise, severe bleeding, severe organ involvement like hepatitis, myocarditis, encephalopathy, and acute kidney disease. These three can be, if any of them is there, that's severe case, or can be all of them. A raising hematocrit may indicate plasma leakage. A falling hematocrit is an unstable patient can indicate significant bleeding. Differential diagnosis is with the malaria. Dengue, there will be rash, retro-orbital pain, leukopenia, but in malaria, there is chill, rigors, anemia, splenomegaly, parasitemia. In a return traveler, do not miss malaria because dengue appears same as like malaria. Dengue with chikungunya. Dengue, there will be thrombocytopenia, bleeding plasma cell. In chikungunya, there will be severe swollen peripheral joints and prolonged arthritis. Dengue with Zika, dengue high fever, marked myalgia, retroorbital pain. In Zika, it is milder disease, prominent non-purulent conjunctivitis, and pruritic rash. And dengue with measles, in dengue, there will be myalgia, leukopenia, thrombocytopenia, but in measles, there's calf, coryza, conjunctivitis, complex spot. Dengue with leptospirosis. In leptospirosis, there would be a history of freshwater, animal urine exposure, conjunctival sufficient, half tenderness, jaundice, and renal injury. Now the common exam trap, this is very important. Normal platelet exclude dengue. They do not platelet may be normal only. So this means this is a trap. Okay, so never think about to rule out dengue if there is a normal platelet, because the normal platelet can be in early phase of dengue. Another trap is improvement in fever. Improvement in fever means that danger has been passed. This is also wrong because the critical plasma leakage phase often begins as fever is settled. This is also important. Now, another thing is give ibuprofen for severe myalgia. If the patient has a very bad pain, muscle pain, you shouldn't give straight ibuprofen. Avoid and feed an aspirin because of bleeding risk if you think suspicious about dengue. The next is severe joint pain always means dengue. Marked, this is also another trap. Marked swelling peripheral joints and prolonged arthralgia favor chikungunya. Conjunctivitis after tropical travel means dengue. This is also a trap. Prominent conjunctivitis with normal platelet favors Zika, cough and coryza favors measles. So think about this too. And a negative early serology exclude dengue. Early disease is better detected with PCR and NS1 antigen. Thrombocytopenia alone requires platelet transfusion. This is also a trap. Treat the patient and clinically significant bleeding, not the laboratory value alone. So now let's do some recall. A 45-year-old man, 3 days after returning from Thailand, the patient has a high-grade fever, severe headache, especially behind the eye, intense muscle and joint pain, diffuse maculopapular rash on the trunk and limb, hemoglobin 145, which is normal, WBC is 3.1, is low, platelet is 75 low, most likely diagnosis, malaria, dengue, chikungunya, typhoid, Zika. This is very clearly dengue, and because there is the classic features, please show the screen of things not to do. Which one? This one? So how long after returning from travel? Dr. We explained that the incubation period, there is, I say the warning sign will happen from day 3 to 7. And then there is another one, day 0 to 5 here. The illness of from starting day 0 and to 5 and also from day 5 above. So, 1 second. So yeah, roughly between 4 to 7 days is the incubation period. So it doesn't matter if the patient came from overseas 3 days before and on day 4 they came to GP with the signs and symptoms. Think about things. If the patient came to your doctor after 2 weeks, and then they say the patient came with 2 weeks and now they have fever or with all those stuff, you have to rule out dengue because dengue, the period which we have to think the incubation is between 3 to 14. So now this is dengue. The next question came in August, June, July. In 3 months, this repeated. 19-year-old returns from Bali, high-grade fever, maculopapular rash, no lymphadenopathy, WBC slow, leukopenia, platelets, and hemoglobin are normal, most likely diagnosis, dengue, malaria, infectious mononucleosis. So we think about the Bali, 1, red flag, high fever, 2, maculopapular rash, 3, and low WBC, 4, platelet, they are normal. Platelet can be normal in early stage. So that is dengue. Because thrombocytopenia is not always present in early dengue, leukopenia, fever, rash. So ABV would have a significant lymphadenopathy with pharyngitis absent here. There was an ABV option in this question in April this year, and we were so confused about the ABV and dengue. So now this is a very good point to know. Lymphadenopathy and pharyngitis is at, if they are in the same, then think about the ABV as well. I think I have ABV in my, if I have it, then we will also do that. Here in visual uses. So once we do that, then it will be clear. So next question, guys. A patient suspected of dengue fever after returning from tropical region while awaiting to confirm serology, most appropriate management. Start doxycycline, oral rehydration paracetamol, start ibuprofen for joint pain, or urgent blood transfusion. So we conservatively manage the patient, supportive care, oral rehydration and paracetamol is the best for the management of the dengue. So instead, aspirin, these are all contraindicated. The next step, a 16-year-old returned from Thailand with a fever of 14, maculopapular rash, bilateral conjunctivitis, red watery eye. These are other things are very specific for dengue, but only this bilateral conjunctivitis, and WBC is also low. Here, you have to go with Zika. Why not measles here? Coryza calf should also be in measles. The next question is what is this? Dengue. Okay, so this question came as a statistic, but it include dengue. That's why it came here. Yes, Dr. Kshana, no calf and coryza. That's why measles rule out. New dengue PCR test study, the true positive was 25 and false negative is 2. So it needs a statistic session, but we won't take any statistic session. This came in July, and we solved that, and the answer was 2 by 27. You have to make a table, and then you have to solve it. The next summary is, remember about the HFT mosquito, which is a daytime biter. Incubation is 3 to 14 days, as I said. And classic triad is sudden high fever, retro-orbital headache, severe myalgia, maculopapular rash. This 4 very important, notifiable disease. Diagnose less than 5 days, do PCR. If diagnosis more than 5 days, do serology. Treatment, bed rest with aggressive oral rehydration, paracetamol only. Warning sign of persistent vomiting, severe abdominal pain, mucosal fluid accumulation, lethargy, and restlessness. And the traps are insect trap, red eye trap, incubation trap, flu trap. We have done all this. The flu trap is new in the older patient with flu-like illness after travel. If rash with low WBC is mentioned, then think about dengue. Okay, so now this precursor I added just now. This recall says a patient who has recently traveled to Bali present with fever, maculopapular conjunctivitis. Investigation shows WBC low platelet, low hemoglobin normal. What is the cause? Measles, dengue, parvo, or Zika. Because of conjunctivitis, we think about Zika virus here because there is bilateral conjunctivitis, normal platelet, mild fever, maculopapular rash, non-prevalent conjunctivitis, arthralgia, leukopenia. Although dengue can cause fever, rash, leukopenia, dengue is more strongly associated with severe headache, retro-orbital pain, myalgia, thrombocytopenia, petechia, mucosal bleeding. So that's why the platelet is normal, conjunctivitis prominent for Zika. Why not measles? Measles have calf coryza conjunctivitis complex spot. Why not parvo? Parvo is causes flapjack, facial rash, followed by a lacy reticular rash. It is not a best explanation for tropical travel. The next question came as a 45-year-old man returned from Thailand with 5 days history of the high fever, severe joint muscle pain, headache, generalized maculopapular rash over the trunk and limb. WBC low platelet is okay, hemoglobin normal. What is the most likely diagnosis? Malaria, leptospirosis, dengue, HIV, infectious mononucleosis. We selected dengue here because this is a combination of the recent travel to Southeast, high fever, severe myalgia, headaches, maculopapular rash, leukopenia, thrombocytopenia, normal hemoglobin. Then this can highly characteristic of dengue. Why not infectious mononucleosis or EBV? This is called pharyngitis, posterior cervical lymphadenopathy, splenomegaly, and lymphocytosis, which is atypical lymphocytes rather than leukopenia. In malaria, this is febrile return from travel, rash and leukopenia are less characteristic. Malaria also can cause fever, chest, anemia, splenomegaly, thrombocytopenia. The next is a woman recently visited Bali and returned approximately 10 days ago. She presented with a febrile illness. Now, I think what's the most appropriate investigation? Dengue serology or malaria cell? Serology after 5 days, we do serology. Now, next question. A 17-year-old has returned from Thailand and present with temperature 40 centigrade, conjunctivitis, malaise, rashes. Blood test shows normal platelet hemoglobin. What is the diagnosis? Dengue and mononucleus parvo. Okay, so here the recall noted that the measles or Zika could be considered as present among the options. So here, none of the Zika, none of the measles given, and the patient also has conjunctivitis. As I said, rarely there will be a conjunctivitis. It is not like absolutely no conjunctivitis. So that's why if none of those is there, so we can go with dengue. Okay. As like Zika was there, so go with Zika. The next recall is a patient has a maculopapular rash and bilateral conjunctivitis, dengue measles. So again, bilateral conjunctivitis is always almost in measles and Zika. If measles is there, go with measles, not with dengue. So here, especially proton facial onset rash is described. The complex spot is in measles, calf coryza conjunctivitis, double, triple C. So the next question, a 19-year-old has traveled Thailand present with a high-grade fever, maculopapular rash, low total white WBC, hemoglobin platelet normal. Again, diagnosis dengue. That is straightforward. The next question, a traveler returns from Bali with fever, frontal headache, myalgia, diffuse maculopapular rash. What is the most like? This is also very straightforward, dengue. Don't think about malaria, measles, chikungunya, Zika. Only chikungunya, there is severe, often disabling peripheral arthritis, especially hands, wrists, ankles, and feet. It's more prominent and may persist for months. The next 28-year-old man returned to Bali from fever, severe frontal headache, myalgia, and maculopapular rash. Again, dengue. So this is all almost repeated but different wording. A patient returned from Thailand, severe myalgia, routine vaccination is complete, but no travel history was found. So what is the, no travel vaccine was received. What is the most likely diagnosis? Dengue fever again. A patient went to Bali, immunization up to date, but the patient do not receive any travel vaccine. The patient has rash all over the body, severe headache, vomiting, no abdominal pain, temperature is steady 8.9, no platelet count provided. What is the diagnosis? Again, dengue, chikungunya, malaria, dengue. Why not chikungunya? Because there is severe peripheral joint pain, swelling would normally dominate. Malaria, rashes unusual. 22-year-old present Malaise fever, headaches. She recently traveled to Bali, received no relevant travel vaccination, and the patient has rash. Again, dengue. So now you know how dengue question came in exam. Mostly diagnosis, and this is the management. What is the most appropriate management for a patient suspected having dengue fever while awaiting for serology? So yeah, this is oral rehydration and paracetamol. And this one different. A diabetic patient he traveled to Vietnam and developed fever, cough, and skin lesion. What is the diagnosis? Dengue, malaria, melioidosis, leishmaniasis. So here, the diabetic added. See how the answer change. See, this is a diabetic patient and travel history, fever, cough, skin lesion. Still, with the travel, fever, cough, lesion, we can go with dengue, but this is another clue in this thing. Melioidosis suspected because travel to South Asia. The diabetic is major respect to pulmonary symptom because of cough is there. And cutaneous lesion, possible soil or water exposure. It's caused by Bartholdiria pseudomyelitis. So dengue is incorrect because dengue causes fever, severe headache, retro-orbital pain, myalgia, rash, sometimes bleeding. It does not typically cause solitary inoculation type skin lesion plus pneumonia. So in exam, they are making very, like they are bringing some clue which would be out of your vision, but you miss it. So try to find the clues as soon as possible because they'll make it some way which you know make it a very small word, not very specific and bolded. That's why they are trying to trick you in this way. The next question. Next question. This is foreign student answer in immunization history. They visited Thailand, returns with fever, aninus, coryza, dry cough, the red eyes, macular rash. This is very specific for result. And this one is different. A patient returned from Thailand 6 weeks ago and had unprotected sex. An HIV test 1 week ago was negative. Patient now has exudative pharyngitis, hepatomegaly, fever, maculopapular rash. What should be tested? ABV, HIV, dengue, or throat swab. We go here with HIV testing with appropriate repeat fourth generation testing because the combination of the resistant high risk sexual exposure, fever, rash, pharyngitis, systemic symptom, and also it can be an acute HIV. A previous testing may be uh, normal or negative in this window. Why not dengue? Dengue characteristically cause exudative pharyngitis. Does not cause exudative pharyngitis. Are not related to sexual exposure. ABV remain an important differential here because exudative pharyngitis, hepatitis splenomegaly, infectious mononucleosis, but exposure history makes the repeat HIV testing essential. Okay. Now, this is some AMDC question. A 47-year-old woman present with a 3-day history of muscle ache, diarrhea, headaches. She also had a fever, pain behind her eyes. She returns from the Philippines and 1 week ago was taking anti-malaria prophylaxis. Blood pressure 118/84, pulse is 120, 112, temperature 39, macular rash over the triangle lens, petechia or mucous membranes, and no neck stiffness. Now, investigation hemoglobin is 136, WBC WCC is 2.7, platelet 91, ALT, AST is high, options bacteria, meningitis, malaria, dengue, chikungunya, Chagas disease. This is dengue because the strongest feature of fever is orbital pain, diffuse rash, mucus petechial, leukopenia, cytopenia, and elevated transaminase, Southeast Asia travel as well. So we have read this. So dengue is done. Oh, thank God. Dengue was very long. So we finished dengue and this episode there. And so let's get scratch. No, doctor, ABV, we can do it later because that is very long. And we can do it next day. So I'm trying to find a short topic because Dr. Kashmala has session today and she will start. I think we can do cat scratch disease or also too much. This topic is Dr. Schizozoomia leptospirosis. Yeah, let's do this brucellosis. That's not too much. Brucellosis is a bacterial zoonosis caused by Brucella, and it's a gram-negative intracellular Cucobacille, which is in Australia, it is also Brucella is predominantly associated with feral pigs, present as an undulating prolonged febrile illness. This undulating and is very good word, and remember this definition again: causative organism is Brucella, Puria, and Australian species is Brucella suis, which is came from pig. Disease pattern is multi-system endolithic relapsing prolonged febrile illness. The risk factor for brucellosis is with the work or occupation. There will be farmer, veterinarians, laboratory workers, laboratory personnel, same as like leptospirosis. Recreational pig hunters, especially in Northern Queensland and Northern Territory, dietary consumption of the unpasteurized dairy product. This was not in leptospirosis, right? So this is very specific for brucellosis, unpasteurized dairy product. Geographic, endemic, and pig hunting communities in Northern Australia, recent migrants from Middle East or Southern Europe. These are all the risk factors. How they present. Incubation period is from 1 to 4 weeks, can extend to 1 month. Undulating fever, as I said, is very common. That just means there will be intermittent spikes with profuse drenching night sweats, and the patient will complain of the wet sheets. All night they will have a wet sheets and night sweats, and also there will be undulating fever. Constitutional presentation is the patient will have malaise, generalized headache, significant arthralgia and myalgia, and the physical exam you will find undulating fever with hepatosplenomegaly with a generalized lymphadenopathy. This three is the triad of the brucellosis. Osteoarticular can be happen in a chronic cases, which the patient will complain of sacroiliitis and spondylitis, which is very common in localized complication. Cardiovascular problems, the patient would have sometimes endocarditis, which is very rare. And neuropsychiatric, the patient also complain of depression or chronic fatigue syndrome. Investigation, For investigation of brucellosis, we do blood culture, which is gold standard, and require prolonged incubation after 3 weeks. Notify lab of suspicious. Serology, we do check IgM and IgG by ELISA or serum agglutination test or SAT. And also we do PCR, which is useful for rapid confirmation of culture negative cases. Once the blood culture came negative, then we do PCR to confirm. Bone marrow biopsy is most sensitive test, but especially in chronic culture negative cases. We do FPE often, which shows neutropenia, thrombocytopenia, and mild anemia, and also imaging can help. But remember, Chick-6A typically cancers are normal, unlike Q fever indicated a focal disease spondylitis is suspected. Okay, so first go with blood culture, which is gold standard serology. We do for longer cases or chronic cases, PCR if the blood culture came negative, bone marrow biopsy is also if the cultures came negative. Management for uncomplicated or in adults and children more than 80 years old, the first line is doxycycline plus rifampicin for 6 weeks. For uncomplicated cases, the alternative is doxycycline 6 weeks plus gentamicin for the first 7 to 14 days. For complicated case, if there is endocarditis or spondylitis, we give the patient triple therapy, which is doxycycline plus rifampicin plus gentamicin or streptomycin for more than 3 months with a specialist referral. And for the children less than 8 years of pregnancy, we are giving trimethoprim, sulfamethoxazole, plus gentamicin or rifampicin. And for public health notifiable disease, we should notify this disease. Okay, so that was the management and now differential diagnosis with Q fever, leptospirosis, listeria, malaria. For the Q fever, distinguishing features exposure to cattle, sheep, gout, present with pneumonia in the X-ray. Investigation is we do phase 2 IgM, IgG, if there is and also there is a high ratio of the ASCLT. Management is short course of doxy for 14 days. The trap is missing the pneumonia, cough, sign which exclude brucellosis. Leptospirosis, there is exposure to contaminated water, soil, animal urine, jaundice, conjunctival suffusion will be there. And the investigation of leptospirosis is serology of PCR. And the management is mild doxycycline, amoxicillin. With severe case, we give IV peptidine. The trap is confusing pig hunters, brucellosis with flood victims, leptospirosis. Remember, the pig hunters is always brucellosis. Vector uses, there will be unpasteurized dairy, soft cheese, and present as a meningitis or sepsis in high risk group. Investigation is gram-positive, raw on blood of culture, management is IV ampicillin, with or without chitta. Mistaken gram-negative brucella for gram-positive listeria. This was also a question from the listeria, and the answer was antibiotic therapy. There was a gram-positive listeria. Okay. Malaria traveled to endemic area, African Rigas and splenomegaly in this scenario, and the differential investigation is thick, thin blood cell. Management is artesunate or other anti-malaria. The clue is here, failing to exclude malaria first in any febrile traveler. Now some points. Feral pig clue any febrile hunter returning from Queensland with sweating, joint pain, think about brucellosis until proven otherwise. No pulmonary involvement, a key differentiator from Q fever, brucellosis lacks respiratory symptom, no cough, no chest pain. Undulating pattern. If the stem emphasizes fever that comes and goes, relapsing, think about brucellosis. The relapse risk, clinical relapse is up to 10% cases even after 6-week course. Never use monotherapy. Now some must do and do not do table. We have to notify the public health. We have to warn the lab of the suspected brucellosis, which is biohazard for the staff. We should use PPE when butchering wild animal or handling carcasses. Handling carcasses, testing this an animal. Investigate for endocarditis. We should do echo if new murmur happen in febrile patient. Don't use monotherapy. Always use combination therapy for prevention and for the relapsing. Rule out if initial 5 days cultural negative. Request prolonged incubation after 3 weeks. Leave vaccines like MMR to susceptible pregnant women. Educate and avoiding raw dairy instead. Don't give MMR for the pregnancy. An important number and cutoff 6 weeks is minimum duration of uncomplicated case. 3 months. 3 months is minimum duration for complicated case, and 3 weeks is necessary for incubation time. To do the blood culture, 10% relapses after completing the full 6-week course. This question, a 42-year-old man came with 5 days history of fever, drenching night sweat, severe headaches, generalized muscle joint pain, recent pig hunting in rural New South Wales, butchered several wild pigs, temperature is 39.4, mild hepatosplenomegaly, generalized lymphadenopathy, no rash, jaundice, or meningism, hemoglobin 135, WBC 6.5, platelet 140, CRP, ALT, AST high, most likely diagnosed. Tularemia, leptospirosis, Bartonella, brucellosis, or Q fever. Here we go with brucellosis because this is caused by brucellosis because the patient is pig hunter, feral pig hunter, and the Dengue fever is there, hepatosplenomegaly and lymphadenopathy is there, night sweat is there, musculoskeletal pain. Leptospirosis need jaundice, renal involvement as well, but in Q fever, they need a pulmonary sign. Tularemia is rare in Australia. Bartonellosis is caused by regionals, not generalized lymphadenopathy after the cat scratch. This question again, farmer with the high fever, headache, nausea, prostration, no cough or respiratory distress. Suki fever is ruled out. Lab shows elevated liver enzyme, no pulmonary infiltrate on chest X-ray. So it is brucellosis. Straightforward. Patient with suspected brucellosis require confirmation and treatment, best initial investigation and gold standard treatment. So 2 questions and 2 question, like they are asking best initial investigation and gold standard treatment, both. So the answer is investigation. We do for initial blood culture with serology. The treatment is doxycycline or rifampicin dual therapy. Summary again, respect to the feral pig hunters and veterinarians, dog handlers, unpasteurized milk, the triad, adolescent relapsing fever, hepatosplenomegaly, lymphadenopathy, investigation, blood culture, initial serology, FPE, neutropenia, thrombocytopenia, and chest X-ray would be normal. Treatment is doxyplacenta or doxyplad rifampicin. Children less than 8 years and pregnant give trimethoprim sulfamethoxazole with Genta. And the graph relapses brucellosis relapse in 10% if 6 weeks is not completed with monotherapy. Pig with cattle trap. Feral pig brucellosis, cattle, sheep, gout, Q fever. Pulmonary trap. Chest X-ray clear, brucellosis. If there is patchy foot infiltrate, go with Q fever. Gram stain trap. If gram stain positive rot in diary, listeria, monocytosis. If no, then if it is gram negative, go with brucellosis. Okay, guys, so this topic is done and it's almost 10 past 10. Thank you very much for joining this session tonight. And I hope you guys enjoy the session.